First industrial or second industrial session today with Abbott, and my colleague and friend Professor Mohamed Farghaly is Professor of Medicine, Dubai Medical College, consultant Dubai Health Authority, and he will talk to us about vaccination, flu vaccination importance. Prof, looking forward to your talk.
Thank you very much. It's my pleasure to be with you here today, and I think we add to the societies which Dr. Abdullah mentioned, the Family Medicine Society. We are talking about an important topic related to the vaccination, and it is proved by evidence over the long period of time that the best preventive way is vaccination. And as you know, the vaccination, always we have the EPI, or what we call it, the expanded program in immunization, where there is an immunization of the under 5. And it's proved that it is the way of prevention of disease, high volume and high frequency, and public health problem disease, which we find the vaccine, and over a long period of time, we are vaccinating against the different disease. Why we are here today talking about the flu vaccines? Because flu vaccines now by the Emirates and the government of Dubai is a mandate. And we updated our mandate to be included influenza vaccine covered by insurance for all the high risk groups. Clicker, please. So I'm going to talk the influenza global prevalence and impact, WHO recommendation for influenza vaccination, different type of influenza and the efficacy of quadrivalence versus the trivalence, and the budgetary impact model, which we did in Dubai to prove that it is cost effective to vaccinate against the influenza vaccine because of the comorbid condition and the hospitalization and the cost of the disease. What's the beauty about Dubai now? That we have the data. And since 2014 till now, we have the big data, which we can generalize from the data we have, and we can convince the payers in order to pay for preventive services. As you know, insurance is always reactive, never proactive. We started to change and to motivate to go towards proactive by vaccination, which is a preventive services, and by screening for diabetes, for cancer, in order to protect against disease. Then, and I'm talking about at the end about the health insurance mandate 2021. As you know, influenza is a global prevalence and impact, whether influenza A or B, it affects 5 to 10% of the adults and the 20 to 30% of the children develop the influenza, whether A or B, every year. And worldwide seasonal influenza can be severe in 3 to 5 millions and can lead to death in 300 to 650,000 each year. If you look to the leading cause of death in 2015 data from WHO, if we are talking about ischemic heart disease and stroke, number 1 and 2, you will find that the lower respiratory tract infections comes number 3. So lower respiratory tract infection were the third leading cause of death globally in 2015. Influenza can exacerbate underlying chronic disease, including ischemic heart disease, diabetes, cardiovascular COPD, chronic obstructive pulmonary disease, and the death attributed to the condition. Influenza is an underlying cause in all this disease. If you look to the Europe data and look to number of 30 communicable disease, you will find the influenza is number 1 in mortality and in the number of cases in Europe. compared to 30 other communicable disease. And if you look to the influenza burden of the disease worldwide, you will find that it is high in middle and low income countries rather than the high income countries. Here you can see again the difference between the number of cases over years in the advanced or the well-developed countries in grays and the blue, the low-income countries. You can see the difference of cases over years, which is high again in the low and middle-income countries. The direct cost of influenza vary widely among countries, and you can find in the high-income countries the difference between the expenditure in cases of influenza per year, $3 to $63, compared to $1 in low-income countries like Thailand. Again, if we are talking about Dubai and what we are doing now in assessing the burden of disease, you can see that we are looking into 3 parameters. Number 1 is the quality of care and the outcome of care. Number 2, the economical, which is this part of the economical effect. And the third one, we are looking into the patient voice or the quality of life, how the disease affected the quality of life of patients. Based on that, you can rank the providers in Dubai, whether they are doing good work or no. What about the WHO position statement? The most effective way to prevent the disease is vaccination. Safe and effective vaccines are available and have been used for more than 60 years. Among healthy adults, influenza vaccine provides protection even when circulating viruses may not exactly match the vaccine viruses. If the strains of the vaccine viruses is not included in the strain running for this year, again, still it is effective. If you look to the seasonal flu vaccination, and first to start with, the WHO recommendation is to cover around 75% of the population with the influenza vaccine in order to reach to what we call the herd or solid immunity. If we are within this room, all of us are vaccinated, there is no way of disease transmission between us. But if the percentage of coverage is low, again, there is a way of transmission of this disease. If you look to the European data, you will find that only in UK and Scotland, they reach the target of 75%. And if you compare between the Western and the Eastern European countries, there is again, you will find that there is a decline in the coverage of influenza vaccine. What if we reach to the target of WHO of covering 75% of vaccine covering ratio? We are going to reduce the number of cases. We are going to reduce the GB visits. We are going to reduce hospitalization. We are going to reduce death and the absenteeism or ways or days away from work. So if you look to the column on the left, which shows the situation now, and if we reach to 75% of our population are covered with the vaccine, how much we can gain both in clinical outcome of care while reduction in the cost. This is what we call it, the value-based healthcare, the best outcome while reducing the cost. Now, who should get the vaccine? We are looking for the WHO recommendation regarding the high-risk population who should take the vaccine. So you look to the pregnant women, they are at risk of getting influenza. And this is proved by systemic review and the meta-analysis of 152 studies evaluated whether pregnancy was a risk factor for severe outcomes following influenza infection. And you can see that there is a high risk of influenza-related hospitalization in pregnant women with the gut influenza. You can see here again in these slides the difference between 1 year before getting the influenza while they are not pregnant, and the time when they are pregnant, whether in the first trimester, second or third trimester, number of cases of hospitalization will be very high compared to the before pregnancy. So there is an increase of 8 times higher of hospital admission in pregnancy with influenza. Again, influenza vaccine of pregnant women reduce the risk of infant influenza. As you know, the recommendation of WHO of giving the vaccine starting from the age of 6. Before 6 months. Before 6 months, still the baby is vulnerable to get influenza. So there is a passive immunity from the mothers who are vaccinated to protect the child during this period. So you are transferring the immunity not only for the mother, or it is again a passive immunity for their siblings. Again, influenza vaccine of pregnant women has a beneficial effect of infant weight and size. Many studies from Canada, many studies from the Bangladesh, both shows that there is low birth weight. Infant was significantly lower in vaccinated mother. Again, less likely small of gestational age, and again, small for gestational age from different study worldwide. It shows that those who are vaccinated are more or less liable to get lower for birth weight. Again, influenza vaccine during pregnancy reduced incidence of preterm birth and infant mortality. Preterm birth, less than 37 weeks of gestation, it is low risk in patients who are vaccinated versus the unvaccinated. The second part, which is the high risk, are the under 5. And you can see that from the data. And data from analysis globally, it shows that 20 to 30% of children develop influenza A or B each year, compared with only 5 to 10% during adult age. And if you can see, influenza in children lead to absenteeism from daycare, school, or work for affected children and their escorts, whether the mother or the parents or the caregiver. They can be away from work because of their sick child. So 76, 73, 77% reduction in absence of kids from schools according to their age. Again, there is absence of their parents from school when their kids are getting influenza. Again, influenza in children is associated with high rate of complication, hospitalization, and medication. You can see that from systemic review of 13 studies examined the burden of laboratory confirmed influenza in Western Europe children. Common complications of influenza include pharyngitis, acute otitis media, febrile seizures, and convulsions. You can see hospitalization, use of antibiotics, and use of antipyretics. All these are costs added to the cost of the disease. Then influenza-related pneumonia is common in young children living in developing and emerging countries. You can see that there is a high incidence of getting pneumonia in developing countries. If the child got the influenza, they are more liable to develop pneumonia. And the influenza vaccine reduced the infection rate in vaccinated children. You can see that in targeted community, 65% reduction in vaccinated compared to unvaccinated. Again, a community-based clustered randomized controlled trials performed in Hong Kong shows the same. There is a reduction in getting influenza in vaccinated children. Influenza vaccine in children reduced the risk of hospitalization and life-threatening influenza illness, and again, it is proved by many studies, and observational studies in US shows that life-threatening influenza illness becomes reduced if your child is vaccinated. If we look about two extremes of age, we are talking about the under 5, and then we are talking about elderly and above 65. Elder age increase the risk of becoming infected with influenza. Immune defense decline with age, so weaken the immune system, more liable to get influenza and its complication. Again, in US prospective analysis assessing the disease burden of influenza A in elderly, up to 67% of infected patients were housebound or bedbound or unable to perform daily activity. To regain to daily activity, there is a reduction or failed of 35% and failed to resume their regular activity in more than 20%. Elder age increase the risk of seroconversion, adverse influenza-related outcomes, age-related deterioration in immune system function can lead to an increased severity of infection. Influenza vaccine in the elderly reduce the risk of influenza infection and the related morbidity and mortality. Vaccinated are 35% less reduction in influenza-like illnesses. In hospitalization, 33%, and mortality after hospitalization, and in all-cause mortality, there is a reduction in cases if you are vaccinated above the age of 65. It is clear and again well understood that elder age group and patient with asthma and chronic obstructive lung disease. If you have a patient with chronic obstructive lung disease and got influenza, there is an exacerbation of the symptoms and asthma attack and worsening of symptoms. Again, there is an underlying pneumonia in such cases, and asthma is most common underlying condition in patients admitted to healthcare facilities with influenza and one of the most comorbidities. Again, people with COPD at the high risk of develop serious influenza complication, hospital admission, overuse of drugs, overuse of antibiotic. Again, influenza vaccine in patients with asthma is associated with important benefits, substantial overall risk reduction of laboratory confirmed influenza, and there is 22 to 41% reduction of asthma and you can find that there is improvement in all causes related to asthma and COPD if your patient is well vaccinated. Diabetes, again, is another comorbid condition when your patient have asthma. This is proved by evidence in 2009 when we have the pandemic of H1N1, and you can see that in patients with diabetes, diabetes tripled the risk of hospitalization, quadrupled the risk of ICU and admission, and doubled the risk of influenza-associated mortality. If you are going to vaccinate your diabetic patient, and as we know, influenza vaccine is indicated for chronic disease, including diabetes, once a year, and the pneumococcal vaccines, and if it is conjugated once in life or every 5 years, so it will reduce the influenza vaccine 56% reduction in any complication, 11% reduction of pneumonia hospitalization, and down the list till 30% reduction in hospitalization for stroke. Patient with cardiovascular disease, again, if you look to the cardiovascular disease and the effect, acute lower respiratory tract infection increases the risk of heart attack or stroke, 5-folds increased risk of first attack, and 3-folds increased in second attack of heart problems. And if you look to the strokes, 3 times increase in risk of stroke, whether it is primary, first time, or subsequent strokes. And the influenza vaccines in patients at high risk of cardiovascular disease reduce the risk of major cardiovascular events. That's why it is recommended by the European Cardiovascular Society to vaccinate patients with cardiovascular disease against influenza every year. Influenza vaccines in patients with heart failure reduces the risk of all-cause and cardiovascular death. As you can see, shift to the left from the midline, that for the vaccinated, there is an improvement when you vaccinate your patients. Again, healthcare workers are more prone to get the disease and are more prone to transmit the disease. So both sides. And many of we talk about absenteeism, now we are talking about presenteeism. It is always you find that we have common cold and we go to work. So there is an increased risk of transferring the disease to our guests and our patients. And the vaccination will improve all this again. Excuse me. Movement. So influenza vaccines, again, will reduce the risk of influenza infection, hospitalization, and absenteeism. So influenza vaccine in at-risk group is recommended by various international recognized organizations, whether the WHO, American Diabetic Association, the European Society of Cardiology, and all other big societies which recommend for influenza vaccine on a yearly basis for our at-risk group. How the vaccines work, the common principles of vaccination, you give the antigen or antibodies. There is a formation of antibodies which will stimulate the immune system. Remember the vaccine, if the patient get vulnerable to the same antigen, there is an antibodies which protect against that disease. Influenza vaccine are categorized into either live attenuated or inactivated vaccine. The live attenuated contain the live virus that have been made less harmful or harmless. So the vaccine, the virus is weakened. It is not quite strong enough to cause the disease, but it is strong enough to stimulate the immune system. Or inactivated, it contains either inactivated virus or viral constituents. Like if we are talking about subtypes of inactivated vaccine, the whole virus, split version, subunit, virosomal, and adjuvants. So you have many types of vaccines which you would like to prescribe. Influenza vaccine are well tolerated across different patient population. Long history with trivalent vaccine shows that it can be tolerable by different age group and different ethnic group. So what is the efficacy of quadrivalent versus the trivalent vaccine? The quadrivalents have 4 strains, the trivalents have 3 strains. Both shows by evidence that it is the immunogenicity of the quadrivalents is not inferior to the trivalents, but the reactivity, again, it is less. Specifically, if we know that the vaccine is from the inactivated vaccine. So the quadrivalent vaccine is induced an immune response at least equivalent to the trivalents for shared vaccine strains in different age groups. We will find this in children, we'll find this in children and adolescents, we'll find this in adults, and we'll find this in adults of different age group. Quadrivalent is not less or not inferior for an immunogenicity of the trivalents, but the reactivity is less. Quadrivalents are highly immunogenic in children and adolescents. So we talk about different age group, phase 3 analysis on the outcome. You will find that it is not inferior, but the reactivity is less. What is the difference between subunit and split vaccines? When we are prescribing the vaccination, we know how the vaccine, the immunogenicity may be of the different inactivated vaccine is the same, but the reactivity will be less if it has particle or it is sub units versus split. So the inactivated influenza vaccine are different type, the whole virus. Vaccine contain intact viruses particles, highest level of reactogenicity, so the immunogenicity is the same, but the reactivity is high. Split, vaccine contain fragmented virus particle, all viral proteins are as well as surface antigen, so sometimes reactivity is high because of the foreign proteins, but if you look to the subunit, vaccine contains mostly surface antigen. So it has the antigen, example HA and NA, better tolerability, low reactogenicity than other vaccine types. Subunit vaccine has similar immunogenicity as a split vaccine, but at less reactogenicity as I mentioned before. Now, I'm talking about a published paper by Dr. Bassam, myself, in relation to budgetary impact model of introducing the quadrivalent vaccine to high-risk group in Dubai. We show that always when we, as I mentioned, when we are talking to the payers or the insurance to do a proactive preventive measures, we should show them data which prove that it is cost effectiveness, whatever we are doing. So the budgetary impact model shows how if we are going to vaccinate the high risk group over a period of 5 years, how much we can reduce the cost. And as you know, the cost is paid by the insurance. So we have the claim data of 2018 and 19, and we show the difference on how if we vaccinate, we are going to reduce the cost. If we are introducing the vaccines to 10%, 50%, 60%, and 75%. So you can see, in conclusion, the introduction of quadrivalence for patients with comorbid covered by private insurance in Dubai will lead to budget saving versus to non-vaccinated. So if I have two groups to compare, one control group and one where we do the action and reduce the cost, so you will find if we reach to 75% vaccination, we are going to reduce the cost by 40% over 5 years, means we are going to reduce the cost of 100 millions, means 20 millions expenditure in health in influenza-related complication over a period of 5 years. Talking to this to the market, make it they understand, and again in July, 7th of July, we issue the mandate of Dubai Health Insurance to make it mandatory for the basic benefit plan, and if it is applied to the basic benefit plan, will be applied to all population of Dubai to give the influenza vaccines once a year for all patients, so we can protect from the cardiovascular disease, protect against any related complication to influenza. I leave you with Expo, and thank you very much for listening.
Excellent. Thank you very much, Dr. Mohamed. So, vaccination protection, how much is protection? 100%? 60, 70?
The vaccination, according to the EPI, is in our what we call it the EPI or expanded program in immunization in Emirates. We are reaching 94 to 95%. For influenza vaccine, we don't have data related to the coverage, but once we started this as mandatory, starting from 1st of September this year, all policies in Dubai, whether old or renewal of policy, should get the vaccine, like what we did exactly for the screening of diabetes. Anyone who is going to renew their visa, they have to do the screening for diabetes. So detection early, intervention early. Again, we applied this for 3 types of cancer: colorectal, cervical, and breast cancer. Screening, early detection, and the treatment unlimited by the government. Pool of funds from the insurance. Again, for influenza vaccine, we are doing this again. We are going with the new policy because the world is going into action. And you can see that data always comes from Europe and the United States. Now we are proud in Dubai that we have our own data and we can generalize from our data to all Dubai.
So, I mean, we know that for extreme ages, old age, young age, pregnant, then chronic diseases. Huh?
We recommend to give the vaccine for everybody, but starting with high-risk group.
Yeah, I'm saying it's really, actually depends on 2 things: characteristics of the patient and the type of the things available. So that's why I think you're going to give it to everyone. That's great news. Any questions? Happy? Vaccine? Are you going to get vaccinated? Who's going to be vaccinated?
The season starting.
We have half at least volunteers.
Yeah, season from September till February. So you are still have the chance to get vaccination.
Especially during COVID, it's much
Yes.
important.
The latest statement from the advisory committee of WHO in relation of COVID vaccine with influenza vaccine. So before, they said that vaccination alone of COVID vaccine. Now, you can give the vaccine simultaneously, means same time, different site, or if there is a space, you keep 2 weeks between the COVID vaccine and the influenza vaccine, or vice versa.
Great.
Thank you very much. Thank you, Dr. Shab.
So now we'll move to the education session. It's pulmonology and Dr. Abdullah and Dr. Bassam, I think, to the others to introduce the speakers for the session.